Hi, my name is Jack Rozel. I'm the Medical Director of Resolve Crisis Services, which is part of UPMC Western Psychiatric Hospital, and I'm an Associate Professor of Psychiatry and Adjunct Professor of Law at the University of Pittsburgh.
Hello, this is Dr. Lorenzo Norris, Editor-in-Chief of MDedge Psychiatry. I'm very pleased to have with us today on this Psychcast Dr. Jack Rozel. Dr. Rozel has been with us on multiple Psychcasts to address issues involving gun violence, mass shootings, and just in general ways in which we can start to think about as clinicians different types of strategies or interventions to stem the tide of gun violence. So please stay tuned for today's Psychcast as it is both timely and informative and something that we all need to hear, given the increasing amount of mass shootings that we have actually seen throughout the pandemic. Dr. Rozel, welcome to the Psychcast.
Thanks for having me back, Dr. Norris.
All right, so Dr. Rozel, by my last count, you've been on the Psychcast 4 times. I actually thought it was 7 because maybe I just wanted to see more of you. But you've been on the Psychcast 4 times, and each time, including this time, each time it's been relevant. We originally wanted to have you on closer to the unfortunate events of Atlanta, March 16th, when we had the unfortunate mass shooting of 8 individuals, 6 of which were women of Asian descent, which needless to say, if anybody's been looking at anywhere media has rocked the country as well as Asian American community, and rightfully so. Since that point, Dr. Rozel, we have had a shooting March 22nd in Boulder, Colorado. We've had a March 31st shooting in Orange County, an April 3rd shooting in Allen, Texas, an April 7th shooting in Rock Hill, South Carolina, and most recently, unfortunately, we're recording this Psychcast right now on April 16th, Friday, but we had another shooting April 15th in Indianapolis when at least 8 people were killed, not including the gunman. You've spoken with us before about mass shootings, and we're going to get to that. But over your appearances on our Psychcast, you've done a very good job of really making us think about, as clinicians, the topic of gun violence, of which mass shootings only make up 1% to 2% of gun violence. And Dr. Rozel, please correct me if I say any of the stats wrong or anything of that nature. So, Dr. Rozel, I wanted if you could start with talking to us a bit about just gun violence in general and paint the picture of where we are at, particularly as we are past the year mark of this unrelenting pandemic.
Yes, it has been a terrible year for our country, for our healthcare providers and our healthcare system at so many levels. The story that dominated the headlines that filled our emergency departments and ICUs was COVID. The other stories, the other trends in healthcare that we maybe didn't get as much attention to, a surge in overdoses and opioid deaths, and a surge in gun violence and interpersonal gun violence. And that last element, a distinctly American issue. Mm-hmm. We saw a few thousand more firearm homicides last year, one of the biggest increases that we've ever seen year over year in US firearm homicides. And there's a lot of different factors that go into that. You know, we talk a lot about mass shootings. That's a bit distastefully, that's what grabs the headlines. Mm-hmm. And if we got rid of everything that we consider a mass shooting, and by the way, there's probably 15 ways to define what a mass shooting is. Mm-hmm. But if we got rid of them, we'd lose maybe 1% of the firearm injury and deaths that impact our country. And that's just thinking of homicides, not even counting the fact that we probably have, 3 firearm suicides for every 2 firearm homicides. It's really, mm-hmm. most of the deaths are suicides. But of the homicides, sometimes it's a lot of people getting injured or killed. Mm-hmm. 3 or 4 people injured, maybe 4 people killed. And by the way, the dynamics of, high mortality mass shootings, something like what happened this morning or last night at the FedEx facility of 8 people dead, has often an incident of that magnitude has very different dynamics, very different phenomenology behind it between versus one where there's like 4 people wounded. And there's so many different ways of defining what is a mass shooting. But you know what? If people are wounded, if people are killed, if our emergency departments are getting a deluge of folks coming in requiring treatment, if we as psychiatrists are responding and working with the witnesses, the survivors, the families, the first responders, you know, it's an issue. And for all of those reasons, I would love to get rid of mass shootings. But again, if we did, you know, snap our fingers, they go away, left with what, 99% of the firearm homicides in our country. Being an adult in the United States means that we are 25 times as likely to be a victim of a firearm homicide than an adult in any other country. And I can tell you that we do not have 25 times the risk factors, 25 times the crime problem, 25 times the violent video game playing as other developed countries. But we got the guns. And it's not all about guns, but it plays a big role. An estimate from a couple of years ago was we have just shy of 400 million firearms in civilian hands in the US. At the time that number came out, this is from the Small Arms Survey, that meant we had more guns in civilian hands than the next 39 countries combined. We had 3 times as many guns in civilian hands in the United States as are in military hands across the world. The guns are part of the equation, knowing that the vast majority of gun owners are safe, smart, responsible, careful, and look on these terrible events with the same shock and horror that every American does. But we have a distinctly American problem because of how many firearms we have, that every once in a while, people get really angry and really pissed and really mad. And if a gun is at arm's length away, terrible things can ensue.
You know, Dr. Rozel, I'm always startled every time I hear those statistics. I mean, it doesn't matter how many times somebody says them, I get startled by them. And one of the things that you talked about in, I want to say your July 2020 Psychcast, was that we had actually experienced more gun sales in the month prior to the start of the pandemic than we had ever experienced at any point in time in our country's history. Yeah. And I remember that. And I remember when you said that, I literally stopped and I said, whoa, this is not good. This is very problematic. I mean, this is why all of the other stats and figures and everything we already knew about our challenge, our problem with gun violence in the country. And this was before we had this big surge in gun sales. When you think about that surge in gun sales, particularly that month, and I'm glad you talked about, you mentioned the overdoses, the increase in homicides. And I'm blanking on the report and there's been a couple right now earlier that forecasted an increase in deaths of despair. All right. And that's kind of what we're seeing now. But when you think about the effects of guns plus pandemic and isolation and mental health, are there any type of things that you want to just share with our audience in terms of maybe how you're thinking about this? Because you said it in July, you're like, wait, I'm letting you know, this happened. And now we're a year later with increases across the board.
So what's really interesting is we're not sure there's a connection.
Okay.
There's a correlation.
Okay.
But at least the early data is that there's not clearly a causative relationship, right?
Okay.
We sold a lot of guns in 2020, right? If you go to the years before 2020, there were maybe 3 or 4 months ever where we'd had like 6 million plus in gun sales a month. I think we had that in 10 out of 12 months last year. I mean, it was, it was another way in which 2020 was unprecedented. And usually when we see a gun entering a home, especially a gun entering the home for the first time, we worry about suicide risks, right? There's a study that came out last spring that said, you know what, in that first month that a gun gets home, the risk of a firearm suicide goes up almost 100-fold. I mean, that's an incredible odds ratio, right? And in fact, we had really cool data from Mike Anestis and his team out in New Jersey, and said, when they surveyed people who were going out to purchase guns, they were more likely to have had current or recent suicidal thoughts than people who weren't purchasing guns or people who were already gun owners. And yet, knock wood, throw salt, whatever, the overall suicide rate went down last year, including for firearm suicide. So for the second year in a row, we had a decrease in the suicide rate in our country, which, what a relief after, almost 20 years of year-over-year increases. But here's what we think, and we haven't really broken it down by the firearms versus non-firearm methods. But while we saw a broad national trend of decreased suicides, what we think is that, as in so many other things that we've been talking about over the past year, a huge disproportionate impact. Some segments of the population had a sharp decrease in suicide rates. And by the way, historically, we go back to other pandemics and we see decreases in suicide rates during pandemics. Some groups appear to have had a sharp increase in suicide rates. And I don't think it's going to surprise anyone listening to this that it's the same populations that have been hit so hard by so many different things, all these social determinants of health, financial disparity, our Black and brown communities, neighborhoods hit by, disparate policing impact, all these other, there's a lot of things I'm thinking of that would get bleeped out on the edit, all these other awful risk factors that are hitting some of our communities disproportionately, that we got to figure out how to do better with. Now, we had an uptick in gun violence, including gun homicides last year. And I'm really curious about how many of these new guns that surged into the marketplace are ending up at crime scenes. Too early to have great data. Part of that gets filtered through the ATF, and they're very tight with how they handle some of that data. But at least from what I've heard, and I actually had an email thread with a colleague of mine in law enforcement in our state just the other day about this, it looks like most of the guns being recovered from the crime scenes, we're not seeing a reduced what we call time to crime statistic, right? So I go out, I buy a gun today, and it ends up at a crime scene at some point in the future. And that interval we call the time to crime. Whether I use the gun at a crime scene, whether I get arrested for the crime, whether it gets stolen from me, whether I was a straw purchaser, what's that interval? We haven't yet seen a shift in that. We've maybe seen an uptick in straw purchasers. There was a huge surge in female firearm purchasers over the past year. And frankly, usually firearm purchasers are male. And we know that a lot of times when females are purchasing firearms, they're purchasing it for the boyfriend. But, we also saw a lot of other groups buying guns that don't normally do. Again, the Black and brown communities, LGBTQ populations, nurses, there's a great article I saw on the surge of nurses buying guns. And the gun dealers were telling us, like, we're seeing people coming in who we've never expected to see come through the threshold. And here's the thing. If you need a gun, if you got to have a gun, you want to be able to use it safely, right? It's like any other tool, right? If you got to have it, it's important to do it safely. And there are fantastic trainers out there and range safety officers out there who are really good at teaching firearm owners and new firearm owners how to safely use and handle a firearm. It's really hard to do that when everything, sort of got shut down because of coronavirus. And one of the things we lost is access to really good teachers to help us be safe with firearms. So it's been tricky, And oh, by the way, we've also had this really interesting surge in what is euphemistically called an unserialized firearm, but most people call a ghost gun, which is where you get a partial piece of a gun from a manufacturer that's not enough of a gun to be regulated by the ATF. And then you do a few engineering things to it. You put it under an auto router, and with some basic engineering skills, you've got a functional firearm that is untraceable.
So a ghost gun, so basically you get some piece of a gun that's not quite a gun, and then you do something. I mean, it's not like are they 3D printing, or are they adding?
So there's a couple pathways to this, and it depends on what your mechanical and tinkering skills are. If you can go to any number of different companies and buy what are called partials, like a 70% partial is what you'll get, because it's not enough of a gun, a 70% receiver. It's not enough of a gun to be regulated by the ATF. But you get this block that's sort of the the part of the firearm where the bullet comes out of the magazine, it gets, the firing pin hits it, et cetera, and it then goes out through the barrel. And you've got to run it through a router or some kind of, cutting device to open up different parts of it. And what you can do is you can buy this block, this partial, and then you can get a program for a CNC auto router, some type of device like that. And you basically sort of punch in the code and you can pop them through, all day long. Or if you're a hobbyist, you machine it out yourself, and, there are enthusiasts who do this. And it's tricky. This is one of the things that President Biden has said, hey, we need some regulation. We need some processing around it. Yep. Hobbyists are going to do hobbyist type of stuff. And there's maybe as much of a First Amendment question on this as there's a Second Amendment question of the knowledge or the programming that goes into, making something like that. But at the end of the day, I think it's a pretty reasonable ask of society that there shouldn't be companies or individuals profiting by putting guns into the crime market. If a hobbyist wants to play and be a hobbyist and, hey, look, I made this with my 3D printer and now I'm going to the backyard and look what I've done with it, that's engineering and whatever. But should it be getting retailed out? Should they be, a private seller that doesn't have to be a licensed firearms dealer saying, oh, look, I'm just, selling a personal firearm person to person. And I'm doing this, every other week through these online forums and making lots of money off of it. Again, if a tinkerer wants to tinker, that's one thing. But should we have a structure in our country where people and individuals and companies profit off of it? I think that's a pretty reasonable policy question.
Dr. Rozel, every time you talk, you give me more and more to think about. The ghost gun, First Amendment, Second Amendment. I was actually even still, that's another Psychcast, but I was actually even going back to what you said in regards to, we can't make a connection, but there's a correlation. And I'm no researcher or anything of that nature, but just one thing that you put in my mind that I was thinking about is something that other guests have said, and something that I think we're all seeing right now, and I think about it, is that COVID reveals fissures in our infrastructure. And I would say that the first to feel those fissures are unfortunately the same populations that suffer from health disparities and the social determinants of health. So that I'll be very interested in seeing how the research starts to bear this out. And it's interesting that you talked about the surge in gun sales, among women. And I remember after like many things, like, I have a conversation with Dr. Rozel, and I'm just, oh man, this is interesting. And, you think about, conversations with your patients about guns, but here's something I'll be interested in what the audience does with this or whatnot. How many of us have actually had a conversation about guns with our friends and our colleagues? Some of you might, it depending on where you're at or your culture, you might, but look, I'll be honest, I never did. So you know what? I'm in like a group text, whatever, kind of with some folks that I know, old school folks or whatnot. And I was talking about, oh yeah, does anybody own a gun? And they all text messaged me shots of their guns, and not like handguns, like AR-15. So I was like, oh, whoa. And it was women, which I'm not throwing a judgment, but I'm just saying when I saw that, and these are folks that I've known for like decades, that I would not have suspected to own that level of firepower. And I thought about what you said in terms of that surge, and now I thought about what you said in regards to different gun owners, but I also think about what your last point about training, access, and proper, because it's a multifaceted issue. We don't want to make a knee-jerk response and say it's as simple as that. So I always felt as though you did a wonderful job of that. Now, Dr. Rozel, speaking of this, what we have seen is the increase in homicides. Yeah. All right. Yes. We do want to acknowledge the loss of communities, Asian American communities, as well as all those who have lost those due to mass shootings. And again, Dr. Rozel already said it. There's many different ways to define mass shooting, probably at least, I think, 10 to 15, depending on what one looks at. But I want to say that the Gun Violence Archive talked about that in 2020, there were roughly 600 mass shootings using kind of their definition compared to 417 in 2019. And so, Dr. Rozel, I just wanted you to comment. I mean, obviously, we're in 2021. I do not know what 2021 is going to look like compared to 2020 or 2019. But I would ask you, Dr. Rozel, when you look at like this, what we have seen recently, is there anything that strikes you, or is there something that's different, or is it, I would dare say, unfortunately, what one would typically see, and it just varies whether or not we advertise it or not, or if it's publicized?
So I'm so glad you brought up the gun violence archive numbers, Dr. Norris, because they saw a huge surge in mass shootings year over year. It's the highest number we've ever seen, by a big magnitude. And their definition is 4 or more people shot, whether they die or not. It's not part of it, not counting the assailant. Now, a lot of people say, "Oh, that's too broad. It's got to be in a public place." They add all these other qualifiers. I almost feel like they're gatekeeping the definition of a mass shooting. But again, people are wounded, and we as health professionals have got to treat them and treat their communities. And I don't think when you're shot, I don't think when you're grieving the loss of a loved one, you really give a damn about someone else's, particular definition. Mm-hmm. Their numbers went way up. You talk to some other researchers who have these much more narrow definitions of, 4 or more people killed. It's got to be in a public place. It can't be targeted or formulated, or, all these other qualifiers. And say, "Oh, look, this was the lowest year ever. This was the best year ever." And in fact, there were even people saying that because some subset of mass shooters are publicity driven, they want these highly publicized, glamorized type of events, that 2020 might have served as a fire break, if you will. But again, the mass shootings were substantial last year. They just weren't making the news. And for all the mass shootings that you've talked about in the past weeks, past months, scores that have happened that will never make more than local news.
It's just, we have to, again, we have a gun violence problem in America, and we have to continue to think about how we're going to solve this multifaceted problem in a way that is just not knee-jerk, and that it's not go with just necessarily the heat of the, like, what just happened at the moment. Because as you just said, this is happening because actually, if you did it, whether it was 2019 or 2020, whether it was 600 or 417, if you just average the numbers out over a year, that's a mass shooting every day. So just because you did not hear about it, it was there. So we really need to start to think about it in those terms. So Dr. Rozel, with that in mind, can you give us some clinical tools that you would recommend for clinicians to always be thinking about in regards to gun violence and working with their patients in regards to gun violence? And if you could, sir, we are now, like everything, we're in a different phase of the pandemic. Yeah. All right. Everybody it's just a different phase. I mean, people are so sick of Zoom and teleconferencing. Folks, I feel everyone, they are dying literally for some type of interaction. They need to get out. They need to be social. But at the same time, you've got pressure with variants. So if there's any kind of tweaks or wisdom you could give us to maybe tweaking how we might intervene or work with our patients in this phase of the pandemic, it would be most appreciated.
Yeah. So, and it's funny because I remember, the first time we met was it was at one of the APA meetings, and I can't remember which one, but we were in a hotel lobby, and you had your sound engineer. We were getting the background noise. It was a lot of fun, right? And I miss those like face-to-face experiences and those overpriced, watered down, hotel lobby drinks. But earlier this week, I spent a couple afternoons logged into a conference for a group that's very near and dear to my heart called the Association of Threat Assessment Professionals. And it's a multidisciplinary group. Psychiatrists were only a minority of the group. There's law enforcement, there's intelligence officials, there's, corporate security types and HR types and, DAs and all sorts of other folks. And we've all come together around one very simple shared mission, that if someone is headed towards engaging in violence, we need to find good, effective ways to stop that violence from occurring, right? We want to get left of bang. If you sort of think of the timeline of, there's the pre-incident, there's the bad incident, that's the bang, the right of bang, right of bang, it's CISM, it's trauma-focused CBT, it's the thoughts and prayers, but left of bang is where we want to be before.
All right, left of bang.
Yeah. And so we've got this model, and actually probably 4 or 5 different research teams converged on almost the same model. And I always go back to the Calhoun and Weston model because it resonated with me as a psychiatrist. And they looked at really interesting research about people who threatened or attacked or killed federal judges. And what they found was what we know about violence: nobody snaps, right? It starts off with grievance. Someone gets annoyed. And we all get annoyed about stuff, and usually it sort of, rolls off our back like water off a duck. We've all also had that experience of interviewing someone where they're defined by grievance and the ways they've been wronged. And by the way, sometimes those grievances are legit. And sometimes I talk to someone who's made a threat and they said, I'm pissed off and angry because this person said blah, 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 blah. And I think, they said, what? Like, whoa. Like, and especially if that was one of my employees who said that, like, that's an HR issue. We're going to fix that. I'm so sorry that happened to you. But please don't threaten to shoot up our building, right? There's a pivot point where someone goes from thinking that they are a victim to thinking that now I can level the playing fields, right? I have been hurt. I can hurt back. And I've seen in the society what happens is people get mad and they bring guns, and that's how they do it. And you may not think you've hurt me that bad, but you have hurt me that bad, and morally what I'm about to do is justified. They do research. It's that change in thinking, that change in attention. I'm going to pay attention to information about my target or about what I need to do to get ready to do violence. Preparation, it's a stage about behavior. Breach is where they've changed the safety of someone. I had someone describe a case to me recently where someone was mad at a business partner, and as the business partner pushed over the desk, he pulls out a gun, points it at the business partner's back and says, decides himself, not today, and puts the gun back, right? A change in the safety of that individual. And then attack. And what happens is risk factors push us up this pathway, and protective factors push us down this pathway. And what we want to do is disrupt those dynamic risk factors and enhance, support, reinforce those protective factors. Now, the first time I ever saw this model, it was on this sort of staircase going up. And I mean, it said, one of my supervisors in residency had a model almost exactly like this. And at the bottom was pre-contemplation, right? Where we had, right? And then you go up a little, it's contemplation. And then, there's determination, then there's action. This is Prohaska's stages of change model, refit or violent behavior. And it invites that motivational interviewing, type of intervention of help me understand, like, it sounds like this person's pissed off. It sounds like they're a real, nasty piece, or why haven't you taken them out? Like, why haven't you gone after them? Like, what keeps you from doing that? What are the protective factors versus what might make it worse? What might make it better? Now, not every act of violence is thought out, premeditated, or planned. Sometimes it's like someone pissed me off about whatever, In Pittsburgh a few years ago, we had someone who was shot and killed because they brought the wrong beer to a party, right? Relatively petty infraction. It probably wasn't an ongoing beef between those two people, but it was someone who's going, you know what? I'm primed, I'm ready. So many people have screwed me over, pissed me off. The next time someone crosses me, I'm ready to take some action on that. And so we look at this model, and as a psychiatrist, I'm really interested in folks who've already started to modify their behavior at that preparation stage, right? They've acquired a weapon, they've changed their timing, their scheduling to encounter this person. Maybe they even thought of like changing their dress or their appearance or getting training in this type of stuff. Or people who seem to be moving up that pathway quickly. Sometimes people take years, even decades to go up this pathway. Rarely people go up it fairly quickly. But it begins with that threat. I'm going to get blah, blah, blah. I'm going to get you. Or that leakage where someone comes into our clinic or our psychiatric ER because someone says, hey, this person just made a threat against a coworker, against an ex, against a neighbor, against a family member. And that's why they're being pulled in to see us. That's our chance to intervene. And again, not because we want to fix this with an arrest or handcuffs or involuntary commitment if we can avoid it. But because a lot of the stuff that drives risk, it's not about a psychiatric diagnosis, but it's about that psychosocial stuff, those contextual risk factors that I think that we as psychiatrists are actually really good at handling, in addition to the psychiatric stuff, right? But we're really good at taking that recovery model approach, thinking about what are the housing issues, the relational issues, the work issues, where are their supports, where are there not supports, how do we help this person as a whole person, not just as a symptom, not just as a diagnosis, because that's such a small part of it.
Well, this is, I remember you talked about this one of the first times you're on a Psychcast. The idea of this, wait, I've seen this before. This is, stages of change model retrofitted to gun violence, and that hopefully for the folks listening, I'm always about, I'm myself. Sometimes when I learn, I'm always thinking, all right, where did this come from? Or was there some other? And then once you do that, then like, oh, I got it. And when you said that, that put a lot in my mind in regards to, okay, this makes sense because, all right, we can start these conversations. Now, I will tell you, this is my own personal view of it. I'm not going to quote research or anything of that nature, and also my own experience at times with trainees, it can be very difficult to talk about with someone their grievance if they really feel safe to speak about the grievance. And depending on your training program, and I was very fortunate that I was trained at Mount Sinai at the Bronx VA by outstanding clinicians. And one of the people I think about is Mr. Mark Benson, who ran an anger management group that I volunteered to attend because people were angry and the threats were real. But you had to be willing to stay in that place and not flinch per se when that grievance is out there. And I don't know if you could you maybe give us anything? Is there anything that you do personally, Dr. Rozel, to stay in that mental sphere without? Let's be honest. When somebody if someone really starts to make a serious grievance, there's, particularly when I was younger, there's a part of me that just wants to run the hell the other way, as comparison to frankly suicide. But so I'm just putting it out there.
I think it's trying to stay anchored to what we are really good at as mental health professionals, right? We are the listening profession, right? Yes. Now, the dialectic here is that we're also physicians, we're also healers, right? We spend a lot of time, we spend a lot of money, becoming who we are. And part of it says, we see a problem, we want to fix it. But we then spend a lot of time in training to learn how to be the listening profession. And sometimes when we're a little bit off balance, we're a little bit startled or frightened, whether it's the patient pouring out these grievances, whether it's someone who's really agitated and pissed off and they're waving their finger on our face, it's really easy for us to go to this fix-it mode. But again, thinking back to some of what we know about motivational interviews, it's about engagement. What can I do to engage with this person, to hear, to listen, to do all of my good active listening stuff, to let this person pour out what they're upset and pissed off about, and sort of hear that and hold that, and then be able to reflect it back and let them know that maybe for once, maybe for the first time, someone really wants to understand what's pissing them off. Like I said, sometimes people come in with grievances and it's, it may be based in psychosis. It may, that the neighbor is implanting, tracking devices on their clothing. Sometimes the grievances are really significant. And it's a window of opportunity to help them out. But the first, you've got to be there with them in their trauma. I'm so angry, blah, blah, blah. This person hurt me. How did they hurt you? And then it's like, right, they're pouring out the trauma story. Like, yeah, that's awful. And that should have never happened to you, to anyone. Let's help you out. Let's get you in a safer trajectory, right?
Okay, Dr. Rozel, tough question coming. Tough question here. In terms of health professionals, who do you feel in this model what would you do in terms of the training of health professionals with this model? And I'm not going to set you up too much, but I mean, I'll tell you where I'm going with it. One of my pet peeves, depending on, again, where you practice, all of these type of things, is that these type of interventions sometimes stay strictly in the arena of psychiatry. And there's arguments to be made pro and con, for that. But even with the advent of telehealth, there has been a psychiatric shortage for quite some time. And psychiatrists are by far not the only mental health professionals, in this arena. But and for listeners, I mean, this gets into where I wear my other hat in terms of like being a dean. And I think about the training of healthcare professionals and how we empower folks to have, like, what are the critical conversations that, regardless of one's specialty, people need to know how to have?
Yeah. So I think of it like screening versus the assessment. For the detailed assessment and management, that's psychiatry. That's our colleagues across behavioral health that are, the pros that need to do that. But for general violence screening, it's got to be all doctors. We've got to know how to ask about violent thoughts, violent urges, and violent victimization. Because, by the way, we're a lot more likely to work with someone who's a victim or even an ongoing victim of violence than someone who's at risk of perpetrating. And we've got to know how to do that in a sensitive, effective way. Now, one thing that's really exciting, in fact, as we wrap up, I'm going to jump onto another call where we're actually talking about possibly sharing a training that we started here at UPMC for our residents. And what I'll do is I'll give your team the link for it. It's the UPMC Well program. I don't recall the link off the top of my head, where in response to some ACGME guidelines, we created a suite of toolkits for residents, fellows, their program directors, their faculty, about how to assess and understand suicide, mental health, substance use stuff through the lens of what happens when the resident is at risk for suicide or substance use or fatigue or things like this. And the way the ACGME regs were written, and it was kind of odd, it seemed like they're actually suggesting, I don't claim to be the right person to read and interpret ACGME regs, I want to be clear, but as I read it, it seemed like they wanted us to create tools to assess residents for risk of violence, like our fellow colleagues for risk of violence, which it happens. It's rare, knock wood. But again, we're more likely to, as residents, to be victims, especially in domestic violence or to work with people at risk. And so we put a lot of that stuff in there. And so our GME leadership at UPMC put together this great toolkit that's open access. It's on the web. And maybe our next step is to be working with the ACGME nationally to make it more broadly available and build out some, we've got the slide deck, but now you'll have me talking over the slide deck for you and other folks. So we're trying to build up some of these tools.
Okay. I thank you so very much for sharing that with us. Yeah, man, that's another Psychcast. I want to hear absolutely more about that, because this is what we're talking about. We're moving from unfortunate events and data that we know to what are we actually going to do in terms of actionable steps, whether it's individual, whether it is in our training. But, Dr. Rozel, what I think about kind of that word, in other words, that you had to stuck with me, is this idea of engagement. Yeah. When we engage as communities, as clinicians, and we meet people where we're at, and we are connected in an authentic way, I like our chances. When anything, whether it's COVID or this or that or psychosis or overdose, divides and we're not connected, that's a path going down a certain way. I always used to tell residents, like, the moment you choose to delay or not see a consult or connect or engage, that's when it's going to happen. That's, as long as we go, as long as we're engaged, we're all right. So, Dr. Rozel, again, you've given us so much to think about. And I look forward to having you back on the Psychcast to talk more about not just gun violence, but training. And we've got, and also, obviously, we're talking about gun violence, we're talking about homicide. And so I need to get you and Dr. Gallagher on the same Psychcast. We got to just start to, as a whole, link suicide and homicide in the same discussion. It's got to become as natural as, absolutely, our mental status exam for everybody, like, is breathing when we talk about these things. And I think that that's going to help us start to make further inroads into this. Dr. Rozel, thank you so very much for appearing on the Psychcast, sir.
Dr. Norris, always an honor and a pleasure. Thank you, sir.